cardiac myopathies, there's three of them. We have dilated, which we're going to talk about here, hypertrophic, where the heart muscle gets thickened and the chamber gets small. That's the last video. And then there's also restrictive cardiomyopathy. And these are all diseases of the heart muscle itself. And with dilated cardiomyopathy, some of the signs you get are just like the other ones. The first signs you start to see are like signs of heart failure, because dilated cardiomyopathy can lead to heart failure over time. So if you have decreased perfusion getting out to your muscles and your organs, you're going to have fatigue in general. And then if you have decreased output, cardiac output, you'll get backflow. You'll get those stretched ventricles, then they'll kind of backflow into the atria. And on the left side, it goes into the lungs and causes congestive heart failure, where you have shortness of breath with exertion and laying down. And then it can continue to back up into the right ventricle, and then up through the right atrium into the superior vena cava and up to the jugular vein and cause that sucker to plump up. It could go down through the inferior vena cava and cause hepatomegaly, enlarged liver, some fluid accumulation in the stomach, or ascites, or edema in the feet, which is called pedal edema. So those are some of the signs. And that stretched heart muscle can also cause some arrhythmias, so that's something that could show up too. But it's a systolic dysfunction because basically that heart muscle just gets thin and can't contract very strong, so it has decreased contractility. And so during systole, that's where the dysfunction is. We can't get that good strong squeeze, so we're going to get fluid just starting to accumulate down in the ventricles, causing them to enlarge even more. And it's just kind of a vicious cycle after that. Some of the causes, 50%, are idiopathic, like we just don't know what causes it. But then there's some causes, like we have a mnemonic A, B, C, D. A and B kind of go together because alcoholism can cause thiamine deficiency, and that's what beriberi is. And so this can be toxic to the myocardium of the heart. Coxsackie B virus, this along with HIV, these cause viral myocarditis, inflammation of the myocardium of the heart. And so that's another cause of dilated cardiomyopathy. And then drugs, this could be like doxorubicin, which is a cancer drug, trastuzumab, which is Herceptin, which is that's a breast cancer drug, and then just recreational drugs, cocaine, methamphetamines, all these different drugs can cause toxicity to the myocardium of the heart. And then regurgitation, it doesn't matter where the valve is regurgitating, it can cause enlargement of the ventricles. Let's think about mitral valve regurgitation. So when we have systole and the left ventricle squeezes, some of the blood goes back into the left atrium, and then with diastole you get more blood coming into the left ventricle, causing it to expand and dilate over time. And then if you had aortic valve regurgitation, whenever during systole and the left ventricle contracts, some of that blood comes right back in, and it can cause enlargement and cause dilation. And then talk about the right side of the heart, you have the tricuspid valve over there in between the right atrium and right ventricle. If it regurgitates, then you're going to have, during diastole, more filling and dilation of that right ventricle. Same thing with the pulmonic valve. If it regurgitates, you're going to have more fluid back in with systole. So regurgitation can cause it. It can also be an effect of dilated cardiomyopathy, because if you think about it, if the atrium ventricles are kind of getting stretched out and enlarged, that annulus there at the mitral valve and tricuspid valve, it kind of widens, and so you won't get a good strong closing whenever those valves shut, and so that can make things even worse. But you can diagnose these through an echocardiogram, that's an ultrasound of the heart, and you can see that those chambers are wide and the muscles thin, and you can look at ejection fraction. That this is kind of a for heart failure, something you look at. Normal ejection fraction is 55% to 75%. So if it's below 50%, that could be another sequelae of this disease process. So treatment, there's a couple things we want to do for treatment. We want to increase forward flow because we want increased cardiac output to perfuse our muscles and perfuse our organs. So how can we increase cardiac output? One is through digitalis. Digitalis is inotrope, and that's going to cause increased contractility, and so you're going to get a stronger squeeze. And then beta blockers, if you get more filling or more time for filling, Frank-Starling law to some extent will help get a stronger squeeze. So Beta blockers can also be used for arrhythmias as well that might be a part of this whole thing, so that you can kind of get two different things working with the beta blockers. And then you also want to decrease backflow, and this will reduce the workload. So anytime, the more backflow you have, the more congestive heart failure you have, and the more problems you have with all the swelling and everything. So if you can eliminate that somehow, that will help that situation. And nitrates are good at this, like nitroglycerin, because these actually can dilate the veins, and that's going to reduce the amount of fluid coming into the heart and reduce the workload of the heart. Same thing with diuretics. Diuretics, in a different way, you reduce the amount of fluid in the circulatory system. That reduces the workload of the heart. And we also want to reduce afterload. When we talk about reducing afterload, we're talking about how tight are our arteries squeezing. If they're constricted, you're going to have a lot of afterload, because that's a lot of force that the heart has to push into. And so if you can reduce the afterload and dilate those arteries, you reduce the workload of the heart. Some of the drugs that do this are ACE inhibitors, angiotensin converting enzyme. This is like captopril, lisinopril. These drugs, they prevent angiotensin 1 from converting to angiotensin 2, because angiotensin 2 will go out to the smooth muscle in your arteries, bind to the angiotensin 2 receptor, and cause constriction. So if you prevent angiotensin 2 from happening, you prevent that constriction. That's going to help dilate and relax those arteries. This works kind of the same way. ARBs are angiotensin 2 receptor blockers. So they go and block the angiotensin 2 receptors on that smooth muscle of the arteries and prevent it from binding. Therefore, you get dilation of those arteries. Hydralazine just dilates the arteries, so that's another one. And then calcium channel blockers, and here I'm talking about the dihydropyridine calcium channel blockers. Those are the ones that are geared more towards dilating and reducing blood pressure by dilating the arteries. So this will be like amlodipine and nifedipine, drugs like that. And then anticoagulants. Whenever you have this blood backing up into the ventricles, or you have it backing up into the atrium, or you have AFib or atrial fibrillation that causes blood to kind of pull up in the atria. Anytime blood sits somewhere, Virchow's triad tells us that stasis of blood causes clots. And so we need a good anticoagulant in the form typically of a factor 10 inhibitor, like apixaban, which is Eliquis, or rivaroxaban, which is Xarelto, or dabigatran, or something like that, to just prevent that clotting with the blood sitting there. So I hope that helps. Here we looked at dilated cardiomyopathy. We looked at the signs, the causes, the diagnosis, and the treatment. Thank you.